want to commend PK for this phenomenal course. So I'm going to talk about different crossing techniques. So, there's no set algorithm. I've been doing this for 7 years, and you have to change it based on, what your patient presents with and what the clinical characteristics are, what is your experience, what's your surgical backup, and also, most importantly, to focus will be what's the angiographic anatomy. So when you obtain an angiogram, I strongly recommend pause for a minute or two and decide what should be the next treatment option. So once you decide what kind of therapy you're going to deliver, you got to analyze these angiograms a little more closely. What is the proximal cap like? What are the collaterals? Is there calcification? What does the main body look like? What does the distal cap look like? And finally, what is the runoff? Are you dealing with ISR? And then finally, what kind of vessel size it is? So the key things when I decide where my primary axis will determine on where the CTO is located, what's the length of it, and also what does the aortoiliac and the common femorals look like. Now, common femoral is being time-tested. There's been millions of cases. Yes, there are complications, but again, this should be the preferred route of intervention. So here's a case in an elderly patient, very tortuous aortoiliac, very calcified. And we decided to go antegrade in this patient. Here's a patient with extensive iliofemoral occlusion, and we had to initiate the procedure through the brachial. Now, this is something which I've been using because the brachial, at least in our program, we've been having at least 40 to 50% complications. So with the axillary arterial axis, which all started with the TAVR, it's a good size vessel, and if you can manage it afterwards with either Perclose or if needed, a short covered stent, it can be considered as an alternative option in certain challenging cases. With the radial axis, I think the biggest challenge I see is difficulty to deal with large bore sheets, very calcified vessels, and not all equipment are made to deal with this. Here's a case where we access the fem-fem graft to open up the contralateral CTO. Again, when you do this, make sure you have to consult with your surgeon. I've had a case personally where we accessed the fem-fem graft and eventually led to graft shutdown, which we finally had to come and revive distally. Here's a case where we had to access the popliteal. Again, this has to be done with ultrasound-guided access, and again, in a very few hand-picked cases. Now, primary pedal approach is like the new kid on block, and it's really gaining a lot of attention. I think we have a dedicated session on this. All I can say is, make sure you get some experience under your hand. Pick a short CTO to intervene on. Make sure you're not intervening on the only last infrapopliteal vessel, and make sure you have a decent size vessel. Now, the next thing is, how do I approach it? So I think it's worth spending at least a minute or so after the angiogram on looking at the cap. If you can't define it, take a few orthogonal shots, see what kind of cap it is. Caps which have a nice beak, away from collaterals, minimal calcification is considered favorable caps. Now, these are examples of unfavorable caps, which are usually calcified, flush occlusions, often involve the common femoral and profunda femoris vessels. And then once you decide you found a proximal cap, you use your interventional catheter, and make sure you find the right spot, because you can easily spiral, as you can see in this picture, as opposed to something which can be straightforward. Also, always recognize the thrombotic occlusion, because you can have a claudican with an ISR with a lot of clot sitting there based on how the angiogram looks like. Have a knack for that to recognize these. Sometimes you can use a catheter like what I'm using here is a vertebral to see if it kind of lodges on to where the proximal cap is, or you can look at the contralateral iliofemoral angiogram and kind of give a perception where roughly the proximal cap is. There's a bunch of devices out there, but end of the day, I think you will get used to one device. And ideally, if you can do these without devices, it's good just because of cost issues. This is a technique where you can sometimes anchor a balloon in the profunda and try to pierce the proximal cap. And again, it's an adaptation from the coronary techniques. Here, where you can put a buddy wire and then try to loosen the cap in a heavily calcified vessel. So crossing the main body, again, if you cross the CTO very, very easily, especially with a catheter without a leading wire, think of thrombus, because that will change your management algorithm. So usually what I do is I use the loop technique. So you create the loop, and then you advance the catheter. Make sure the loop you've created, the diameter of that has to be usually lesser than the diameter of the vessel. And often it's a feeling where you're actually pushing through as opposed to slicing. And when crossing ISR CTOs, it's very important that when you enter the stented segment that you're inside the lumen, so make sure you take a few orthogonal views. And again, same technique, I'm sorry about the pictures, with the loop. Now, when you have a calcified vessel, that adds a whole bunch of challenges. So when you have a calcified vessel, a couple of techniques. One is you identify where it is, and then you can either find a channel and you're able to get through it. In some techniques, what I've done is you come retrograde. And when you come retrograde, what you can do is you can find another channel. And in some scenarios where you're not able to get through retrograde, then I've done something what you call as transcutaneous calcium fracturing, where basically under ultrasound, you define where the calcified segment is, make sure the patient is well anesthetized, and then you actually poke the calcium with a cooked needle. And this way you kind of create a few channels, and then you're able to enter through the CTO. So that's one technique of getting through the calcified vessels. So anyway, once you've done with the calcified vessels, and that's a big challenge. The other option is, you sometimes have to get a dual axis. That is, you have to go retrograde or pedal. So often what I do is, depending on how the vessel looks like, you can go between a 014 system or a 035 system. So usually I try to start off with the 014 system, but sometimes the vessel is calcified, long CTO. I put a 4-5 slender sheath into the pedal axis, and then you can use once again, a stiff angle glide wire and a support catheter to cross through it. And then once you've crossed through it, a couple ways of externalizing the wires. Either you can feed into the contralateral catheter, which can be done by finding the smallest region, or you could snare these. So this is am I good to go? Yeah. So this is the additional accesses which we talked about, which I'm going to skip. The other option is accessing the distal SFA if all you have is a one vessel runoff in the foot. And sometimes you have to actually access the stent itself, where you do it under ultrasound guidance. And then make sure once you access it, you use a 035 glide wire and you create a loop technique, make sure you're orthogonal. Sometimes you access the occluded vessel itself, which is the SFA, as seen in this example. And this is about how we cannulate the externalized wire with snaring, or you feed directly. Some advanced approaches is you cannot really make both ends meet. What you do is you kind of dissect that region. You know you're going to stent this extensively. And this is obviously done after you've explored all the other options. And after you snare it, then you externalize it. And then here's a modified card technique, which you can also adopt into your practice. End of the day, I think the level of regressivity will depend on your experience and your surgical backup. But I would say the key points is take some time in looking at the angiograms, defining the proximal cap, the distal cap, the main body, and then eventually what you're going to treat this with. Thank you.